Hello there, my name's Dickon Hayne. We're at the ANZUP conference and I'm the pleasure of talking to Peter Black about bladder cancer and specifically aspects related to changes in immunotherapy in bladder cancer. So thanks for talking to us, Peter. I think let's start in the more advanced setting. There's so much going on. It's kind of bewildering for urologists and med-oncs as well. So firstly, could you tell us what you think are the current trials that are going to be most elucidating in this space, and then move on to your top picks for where things are going with the advanced setting?
Yeah, so absolutely, yeah. There's a dizzying number of different trials going on right now, and we have 5 different drugs, 5 different checkpoint inhibitors that have been approved in the United States, and their approvals trickling through in different countries, including Australia. And it's all in patients with metastatic bladder and upper tract disease who failed prior cisplatin, so cisplatin, or platinum in general, so carboplatin or cisplatin. And we've seen good results, so about 20% will have a response, but obviously there are a lot of patients who still are not responding. So one thing that we are seeing as things move forward is that these drugs are moving into different disease states. So we have trials now also in the adjuvant setting after radical cystectomy. There are 3 different trials there. We also have some neoadjuvant trials going on, and then it's also moved into the non-muscle invasive disease setting. And then the other thing that we can expect in the future are combination therapies. So there are a lot of trials ongoing with one of the established checkpoint inhibitors plus either another immunotherapy or in addition to chemotherapy or in addition to radiotherapy. So there's an awful lot going on. And then there's also a very rich research area around biomarkers and which biomarkers can we use to select out the 20% of patients who really are going to benefit so that they get the treatment and the other patients move on to something else.
So I'm interested to hear you mentioning trials in the adjuvant setting. Obviously, those of us who perform cystectomy and you've got high-risk patients, they've had neoadjuvant chemo and they've still got T3 disease, or perhaps they've still got anyone with positive lymph nodes at cystectomy. They're maybe fit patients. They're the ones you really want to hit hard. You really want to try and cure those patients. So can you tell us any more about any studies looking at that group and what?
Yeah, so it's exactly those patients. So it's patients, if a patient has had neoadjuvant chemotherapy and still has any muscle invasive disease at the time of cystectomy, that already counts for most of these trials, or for all 3 of these trials. And then any patient, regardless of neoadjuvant chemotherapy, if they have T3 or greater or node positive. And it's very attractive because it's relatively easy therapy to give. It's very well tolerated. It's much better tolerated than chemotherapy. We know that we have challenges giving adjuvant chemotherapy in some patients post-cystectomy. This should be easier, and so it's very compelling. In the neoadjuvant setting, of course, the problem is that if you only expect 20% to respond, we're going to be reluctant to delay cystectomy for that kind of response rate.
And what about combination immunotherapies, a PD-1 or PD-L1 and CTLA-4s? Is anyone using that in an adjuvant setting in a study that you're aware of, or is that a...
I wouldn't be surprised if someone's doing it somewhere. I'm not aware of a bigger trial with it. I mean, the adjuvant trials with single agent PD-1, PD-L1, they're all phase 3 trials, lots of patients, but there may be smaller trials. The trials we have seen, again, are in the second line metastatic. There are combination trials, and I think one of the most interesting trials has already completed accrual, which is in the first line metastatic, so no prior chemo, where patients are either getting, trials finished accrual, but they got durvalumab alone, which is a PD-L1 inhibitor, or they got durvalumab plus tremelimumab, which is a CTLA-4 inhibitor, or regular chemotherapy. And so that's going to be very interesting in the first line.
Three-way randomization.
Three-way randomization.
Yeah, okay. It'll be fascinating to see the results of that one. So what about the non-muscle invasive setting? Because the urologists in Australia, we're obviously, that's where we're likely to be more directly involved in the immunotherapy space. Are we going to be giving these patients immune therapies? How are we going to deliver it? What's going to be happening?
Yeah. So I think right now, second line metastatic, you say, well, as a urologist, I'm not in that space. I don't need to really know it, but certainly adjuvant, yeah, we certainly need to know it. Those are our patients that we're sending on, and then In the non-muscle invasive setting, yeah, the question is, should we be doing this ourselves? I think for the most part, we'll have to work in close collaboration with the medical oncologists, and they will be giving the agents. But there's some compelling reasons why these drugs should be tested in clinical trials in patients who failed BCG. And so there are 3 different trials looking at this, and one of those trials is open in Australia and New Zealand. And it's a paradigm shift. We're giving systemic therapy to patients with non-muscle invasive disease, but we know this is high-risk disease, high risk of progression. There is a mortality risk, and so I think it's something that patients certainly embrace.
How would you feel about us at this stage, because we have very little information about how these drugs may work in a non-muscle invasive setting? How do you feel about trials which might utilize immune therapies up front against best practice, which would be BCG with maintenance?
Yeah, so I think that's challenging. Again, if we look at this magic 20%, it's not really a great response rate by itself. So more patients will respond to BCG than that. So I don't think we should be trying to necessarily replace BCG. I think we want to build on BCG. So I think the trial design in the patients who have not yet failed BCG should be BCG alone versus BCG plus new drug. And there are trials coming up in that space. The BCG failure population is attractive for the companies because there's a clear pathway towards FDA registration. So that trial space, the BCG refractory, or what we're now saying unresponsive, is a very busy trial space.
And then there aren't that many patients. It's quite hard to...
Yeah, exactly. There's actually a lot of competition, shall we say, for the patients to get them enrolled on these trials, which, it's great if we can get these trials done, and it's great for the patients if they're exposed to novel therapies, but it is challenging to do it.
Okay, that's been very interesting. Thank you very much.
Thank you.